Welcome everybody to this webinar, and thank you to those who are joining us live and those who will be listening afterwards. I would also like to welcome our panelists who are joining us today, and I'll introduce you to them shortly. My name is Paul Fahey. I'm a chair of the FIP Working Group on Data. Just by way of background, I'm a director of my own consulting company in relation to focusing on corporate governance, digital health and patient safety. I previously owned and operated a community pharmacy here in Ireland. I'm also a chartered company director and I'm on the board of Epilepsy Ireland. I've also had roles within administration and digital health in the Irish pharmacy sector. Today, my co-moderator is James Stevenson from the USA. And perhaps, Jim, if you would like to introduce yourself.
Yeah, thank you, Paul. Hi, I'm Jim Stevenson. I'm Professor Emeritus in the University of Michigan College of Pharmacy. I served as Chief Pharmacy Officer in the University of Michigan Health System and Associate Dean for Clinical Sciences in the College of Pharmacy. I also served for 3.5 years as president of Visant, which is a medicines management consulting company. Subsequently, I served as Chief Clinical Officer for Omnicell, which is a medicines use technology company, until I retired a few years ago. I have served in the past on the board of directors of the American Society of Health System Pharmacists, and I'm a fellow of ASHP and of FIP. And I also have the pleasure of working with Paul on the FIP work group on data. So pleased to be with you today, Paul.
Thank you very much, Jim. Just by way of housekeeping, this webinar is being recorded and live streamed on YouTube. It will be available afterwards at the address www.events.fip.org. You may ask questions using the Q&A box provided in the bottom panel of your screen. You are welcome to provide feedback to us at webinars@fip.org. And I would also encourage you to become a member of FIP, and the address is there to register and become a member. The benefits include access to many professional programs, FIP Seal awarded programs, which are being accredited to training, and they're really, really good. So just by way of introduction to FIP as well, FIP's vision is for a world where everybody benefits from safe, effective and quality and affordable medicines and health technologies. And our mission is to support global health by enabling advancement of pharmaceutical practice, sciences and education. And we're pleased to be delivering this event entitled Harnessing the Power of Data in Antimicrobial Stewardship and the Use of Data in Benchmarking Antimicrobial Use and Improving AMS Programmes Performance. This webinar was developed by the FIP Working Group in Data, which is a subgroup of the FIP Technology Group. The Hospital Pharmacy section, the Community Pharmacy section, the Health and Medicines Information section and the Research Special Interest Group in FIP have also been involved in this webinar. And for people who wish to explore more about FIP's work on antimicrobial stewardship, the event organisers will share with you a link to the FIP Statement of Policy, which is entitled Mitigating Antimicrobial Resistance Through Antimicrobial Stewardship. You will see that in the chat box later. By way of background as well, data itself plays a crucial role in optimising AMS programmes. It helps us to enable benchmarking of antimicrobial use, to identify prescribing trends, and to measure programme effectiveness and outcomes. Leveraging data-driven insights helps healthcare professionals and institutions set targets, track progress, and implement evidence-based interventions to optimise antimicrobial prescribing practices. Leveraging data-driven insights helps healthcare professionals, ourselves, and institutions set targets. And this webinar hopes to focus on the use of data to power antimicrobial stewardship programmes with a particular focus on enablers and obstacles to developing successful programmes. So no matter what part of the journey you're on, if you're at the start of your journey developing AMS programmes, or you're more sophisticated and you have enabled them, you will learn something from this webinar. Our learning objectives today is number one, to understand the importance and use of data to develop successful AMS programmes, to explore the need for data standards in common terms to benchmark antimicrobial use, burden, and in improving AMS programme performance in hospital and community settings, to recognise data standards currently in use, to explore some examples of good data collection both in community and hospital settings, and examples of successful data-driven AMS programs, and also to understand the challenges faced by developing countries in the use of data in benchmarking antimicrobial use and improving AMS program performance research, and also the possible use of indicators to retrospectively estimate antimicrobial use where hardcore data is not available. So as I said before, this event is being live streamed. Just by way of housekeeping as well, unfortunately, one of our speakers, as advertised, Fiona Doukas from Australia, wasn't able to join us due to a personal issue. We wish Fiona well, and we hope to have Fiona present again at another webinar, perhaps a repeat of this webinar or similar themed webinar. So watch out for that going forward. And without further ado, I would like to introduce our first speaker, who is Luna El-Bizri. Luna is from Lebanon. She is also a member of the FIP Working Group on Data and a very valuable contributor to that. She's the founder and manager of Luna Pharmacy and is a member of the Digital Health Task Force at the Lebanese American University. She also has experience in the development of Phoenix, which is the health record used in the Ministry of Health, primary healthcare centres in Lebanon. Luna is a key participant of the Meditrack project, and that's a track and trace system used by the Ministry of Public Health in Lebanon. She is also a member of the FIP Health and Medicines Information Section Executive Committee and is a member of the FIP AMR Commission. So Luna is a very busy lady, but Luna's presentation today is entitled The Challenges in Data Collection in Developing and Low-Income Countries. And then, would it be possible to create an indicator for retrospective use? Luna will update the webinar on the latest research in the Lebanese University in Beirut. Thank you. I'll hand over to you, Luna.
Hello, everybody. Thank you for this nice introduction. Today, we're going to talk about a very challenging, the slide that is before, the challenges. We're going to talk about, next slide, please. We have so I will talk about the challenges because we have some slides that are missing. It's not a problem. We're going to talk about why in low and middle income countries, especially in these areas, the surveillance data is very challenging. You should know that we do have a weak laboratory infrastructure because many low and middle income countries lack accredited and standardized microbiology labs. We don't have routine antimicrobial susceptibility testing, and this impairs accurate resistance for tracking the antibiotic and the resistance. And we do have limited availability of culture and diagnostic tools, which hampers proper identification of pathogens. Number two, we do have inadequate health system governance. For instance, we have in Lebanon, we have in many low and middle income countries, we do have action plans about tackling and mitigating AMR. But unfortunately, many of them, they exist on paper and lack clear implementation frameworks. And this is due for many reasons. For instance, we do have a weak interministerial coordination between the Ministry of Public Health, between the Agriculture, between the Ministry of Environment, and different sectors leak this intercorrelation, intercoordination, and intercooperation. For this reason, this insufficient regulatory enforcement will implement the good tracking of information and data. The third reason is a poor health information system. In low and middle income countries, we do have fragmented collections of data among different systems. We have sometimes a paper-based collections of data. And this will limit the capacity really for the real-time data analysis and sharing. And we will have a lack of integrated AMR surveillance platform at national or regional levels. Finally, the third and the fourth and last challenges in low and middle income countries is the constrained financial and human resources. Unfortunately, in these countries, the priority are not for the surveillance or the collections of data for AMR. We do have other priorities, and we do have limited funding allocated to AMR surveillance initiatives and other information regarding the AMR. And this is will limit the activities for data information about AMR and bacteria and pathogens and AMR susceptibility. So this is the first thing that we should take care of when we are talking about AMR. Second, we do have the case that we're going to talk about it. It is about Lebanon. In Lebanon, we have the same problems, the lack of regulations at the level of a human use. For instance, in Lebanon, we do have a law that prohibits the prescriptions of antibiotics and antimicrobials inside the pharmacy without dispensing without a prescription. Unfortunately, over-the-counter access contributes to self-medication, misuse, and inappropriate dosing, and weak enforcement of the existing pharmaceutical regulations allow this irrational prescribing and dispensing practices. Number two, another challenge, which is a very important one, is the lack of surveillance of antibiotic and use and resistance. We lack in Lebanon a national data on antibiotic consumption patterns, and resistance strains are scarce or fragmented. We don't have a national platform where all, let's say, institutions, hospitals, other information sources will put this data about AMR in this platform. Also, we have a limited participations on global surveillance network like the GLASS. Third thing challenging in Lebanon is a lack of continuous medical education for prescriber, notably the prescriber at the level of primary health care. So many prescribers lack up-to-date knowledge and continuous education about AMS at the level of the primary health care and the current treatment guidelines. And this will really challenge, will form a challenge for the AMR and the tracking of the AMR. Lastly, we do have a limited microbiological laboratory capacity, not in all laboratories, but many healthcare facilities lack well-equipped microbiology labs capable of conducting reliable antimicrobial susceptibility testing. And this inconsistent quality standards across the laboratories will hinder accurate diagnosis and resistance tracking. So now I'm back to the next slides. Yes, next slide. No, go to the first slide, please. Yes, now we're back to this. We missed 2 slides. It's not a problem. What the Ministry of Public Health has done, Ministry of Public Health have created many task force, as you can see, concerning AMR and the war against AMR. One of these tasks is the AMR surveillance task force. But unfortunately, this task force is still just on the paper and nothing is implemented yet. And this is the major problem that we can see in low and middle income countries. Next slide, please. Okay, so what is really done in Lebanon and what is happening now? Well, one of the good achievement that is happening is the CDC collaboration, which is the Center for Disease Control and Prevention at the States, selected especially the American University of Beirut to join the Global Antimicrobial Resistance Laboratory and Response Network. This is very important because this initiative aims to strengthen AMR surveillance, diagnostic and outbreak response in participating countries such as Lebanon. And this is a very huge step towards really enhancing surveillance and collecting information and data about AMR. So the AUB's inclusions reflects something important, that it is this advanced laboratory capacity, its commitment to regional AMR surveillance. The partnership will enable technical support, data sharing, and training opportunities, which is very critical for building Lebanon's national AMR response infrastructures. What others data that can we collect concerning antimicrobial resistance in Lebanon, this low middle income country? We have individual hospital antibiogram. For instance, as you can see in this figure, we do have the AUB hospital antibiogram, the American University of Beirut, as well as of another academic hospital, which is the Maqasid General Hospital. So we can have a summary of antimicrobial susceptibility patterns from their own microbiology labs, and they will help really to guide about the trend of local resistance in Lebanon. But however, even though that we have this individual hospital antibiogram, there is no national mandate for their standardizations or public reporting, leading to variability in data quality and usage. Number two, we have also the data coming from aggregated antibiogram, and many Lebanese hospitals generate institution-specific antibiogram or from other private laboratory, which they have their own data. Again, it is a fragmented system. We don't have this national platform. Finally, we do have which is happening. The aggregated, we have this studies which can give us ideas about what is happening, and they are conducted, often led by academic institutions, and to evaluate resistance patterns across different Lebanese healthcare centers. So as you can see here in this photo, the different sources of information that we can build to have data about AMR in Lebanon. It is the literature review, it is the microbiological laboratory test, it is the hospitals, but again, it is something that is fragmented and not under the national platform. Next slide, please. So if we want to see what is really lacking, we have lack of standardization of techniques, definitions, and breakpoints. What do we mean by that? Currently, variability exists across laboratories in Lebanon regarding microbiological testing methods and interpretation standards. So we don't know, we don't have unified protocols for culture and sensitivity testing. Each laboratory will adopt a different standards, and this will have a difference when we are collecting, if we want to collect data. Number two, we don't have a representative of the whole country. Usually, most AMR data in Lebanon comes from the big institutions, the well-equipped hospital, as we have seen with the American University of Beirut Medical Center or the Maqasid General Hospital. We don't have data collection from other hospitals. Also, the data will come also from urban areas, especially in Beirut. Rural, underserved areas remain underrepresented, leading to some data gaps. Another thing, the third thing, is the continuity of surveillance. AMR data collection in Lebanon has been always projected or fragmented. So we need really this consistent long-term surveillance mechanism and some support, policy support to ensure ongoing monitoring. An example a little bit far from AMR, one good thing that Ministry of Public Health that has done during COVID, collecting really good data and asking people to collect, for instance, any side effects. We can do that when we are talking about AMR, but we need this cooperation and coordination. So these strategies for the data preparation is very important. Surveillance efforts should be use more user-friendly formats for data. We have to implement new systems. We have to link surveillance to policy and action, because if we want to have data, it's not only to have data, because we don't just want to have some data. We have to be translated into policy and practice. And this is very important for the good performance while we are talking about AMR and AMR information. Next slide, please. Now, if we want to talk, we have talked about the hospital, about the laboratory, but we didn't talk about collecting data from one of the big resources, which is the primary healthcare settings. In Lebanon, we do have two types of primary healthcare settings that can give us valuable information about AMR, which are the primary healthcare centers and the community pharmacies. The primary healthcare centers are the ones that has been established by the Ministry of Public Health. They call it in 1996 as the National Primary Healthcare Center Network. And to make this primary healthcare center with the good standards, the ministry created in 2009 the National Primary Healthcare Accreditation Program, where each primary healthcare center has to abide to some standards, international and national standards, to gain points and to be accredited. And when primary healthcare is accredited, this is a sign of a good quality of this primary healthcare. So primary healthcare centers were wanted and eager to have these points and really to have this accreditation. What is the difference between community pharmacy and these PHCCs? The difference that they offer free of charge most of the or affordable prices, most of the university health coverage, medications, immunizations, and this essential treatment for people. Next slide, please. Well, the Primary Healthcare Center Department in 2016 has generated a National Health Information Center to be used, and it was the first unified system that linked almost 300 primary healthcare centers' data to the Ministry of Public Health. So if a patient will go to one of these centers, and then the second day will go to another primary healthcare centers, they will know what he has taken, what are the medications, if has been prescribed an antibiotic, if has been prescribed another medications, if has taken a vaccination. So this relations was done with this unified system, which is called Phoenix. And this platform was very important because it is the first time that the Ministry of Public Health is able to collect data from these primary healthcare centers. Next slide, please. Well, to have accreditation, as I have said, you have to have points. And the antimicrobial resistance is one of the between two brackets grades that they have to earn so they can get accreditation. How the inspectors from the Ministry of Public Health are tracking if the primary healthcare center is abiding to the rule of the recommendations of the ministry according to the dispensing and the prescriptions of antibiotics and antimicrobial. Well, the Ministry of Public Health has adopted the ICD-10. What is the ICD-10? It is the International Classifications of Diseases, the 10th revision. This is a global standard developed by the WHO. It is used to classify and code all diseases, health conditions, and causes of death. So we're going to match the prescription to the ICD-10 codes. The nurse, the pharmacist, the physician are well trained about this ICD-10. So they have to assess the appropriateness of the antibiotic use. They have to identify the overuse in non-bacterial infection, and they have to support stewardship intervention. We're going to see an example in the next slide. Next slide, please. So, what are the audit steps that the inspectors are doing? First, they're going to see the list on antimicrobial prescriptions. Second, they're going to extract the association with ICD-10 diagnosis. Third, they match the diagnosis with the necessity of antibiotic use. Fourth, they classify if it is an appropriate prescription and dispensing, or it is not inappropriate, or it is inappropriate one. And then they report the findings for clinical improvement. And of course, this is going to have, or they're going to gain a grade, the primary healthcare center, or they're going to lose this grade. For instance, as you can see here, I have just taken invent scenario. For instance, the code for sepsis is the A419, sepsis unspecified. If the antibiotic prescription was a broad spectrum antibiotic, does it match the ICD-10? Yes, it does. So it is correct and justified. If, for instance, the common cold, which has a specific code, broad spectrum antibiotic, and it doesn't match, so it is incorrect and antibiotics not needed. At that moment, the inspector will ask the pharmacist in charge why he permits this dispensing. If the dispensing of this antibiotic, if the pharmacist didn't call the physician and didn't ask why this antibiotic has been prescribed, the primary healthcare center will lose the point and the accreditation. If the pharmacist has done his job and has made this interaction with the physician, and the physician has insisted to have this antibiotic, the pharmacist at that moment has to put the note that the counseling has been made, but the physician has refused this, and then the problem will go to the physician. Next slide, please. So the problem, even though that this is a good system for only the primary healthcare centers, they were accredited or not, they have this system, and they have to report the number of medicine dispensed in general, including antimicrobial. The problem is that this Phoenix system is only applicable and adopted by the primary healthcare centers. For instance, I am a community pharmacist. I do have a community pharmacy, but I cannot access Phoenix because I am not part of the PHCs. So let's say patients can come from a primary healthcare center to my community pharmacy, and I'm not able to know what has been prescribed, what is these diseases, etc. So this is number one. And number two, we have a limited national data linking prescription to ICD-10 codes. It's only in these primary healthcare centers. The main challenges really is to have a standardized diagnostic codes everywhere, in the hospital, in the primary healthcare center, with the physicians at their private clinics. And we have not only to rely on our clinical judgment without confirmed diagnostic, and we have this resource constraint impacting surveillance. So still now, we do have, even in these primary healthcare centers, a persistent overprescription for antibiotics for viral infection. And we have this difficulty measuring real antimicrobial user patterns. Next slide, please. Now we have finished the first part in the community, which are the primary healthcare center. We now coming to our community pharmacies. What is happening in the pharmacies in Lebanon at the level of the community? Well, unfortunately, as in other low and middle income countries, dispensing and purchasing antibiotics without prescription, even we do have a law, is done and practiced. We don't have a unified e-medical record. Only it is fragmented. Academic hospitals have their own medical records. Primary healthcare centers have their own medical records. And we cannot access these e-medical records. Number three, pharmacists, they don't have their own e-medical record, the community pharmacies, like the hospitals or the PHCs. This is a third constraint and challenge. And unfortunately, the national record of dispensing or prescribing is not available yet, and only it is stratified as usual. Next slide, please. I'm just showing you that we as pharmacists have to avoid two different guidelines. One of these guidelines is the one that has been a joint FIP-WHO guidelines on GPP, on good pharmacy practice. And it is clearly noting that, for instance, pharmacists should be prescribed in reducing antimicrobial resistance by providing information about the appropriate use of antimicrobial. Another example, for instance, that pharmacists should document necessary clinical and patient data to assess and monitor medication. And this is implemented, of course, on antimicrobials and antibiotics, especially in antibiotics, because we do have lots of antibiotic dispensing without prescription. So it is very important to document, to track, and to implement what we call the 4 rights for the medication: the right treatment, the right dose, the right period of treatment. And we don't have this tracking till now in Lebanon. Next slide, please. This is a study that has been done especially at the level of community pharmacies, and they were tracking if Lebanese community pharmacy are abiding to the GPP, the good pharmacy practice, in their pharmacies. And they have, to make it easy, they have divided the indicators for this good GPP practice into 4 indicators. The first one is the data management and data recording, and this is very important if we want to collect good information and data. And we have the indicator C, that is the dispensing and preparation, administration and distribution of medicine. And this will allow us to know where are these medications, these antibiotics are going, what are the doses, where we are distributing. And if you look at the results, we can see that 64% of pharmacists in Lebanon, they don't have a patient medication profile even in their community pharmacy to report data. We need at least a patient medication profile. And they don't have even books to patient medication profile. And 39.5% dispense antibiotic without prescription. And this is a huge number. And finally, the result of the study showed that only 23.3% of pharmacists were adherent to indicator A. And this means that only 23% of pharmacists now at present in Lebanon are collecting minimal data about data management and data recording. And this is, and how can we going to track AMR and the trends in AMR if we have only 23% data about it in the community pharmacies? Only 14.8% of pharmacists were abiding to indicator C concerning the dispensing, preparation, administration. So we don't know who is dispensing, what we are dispensing, the number, the dose, etc. Next slide, please. For this reason, we have to abide to the rule. By law, we should, as community pharmacists, retain a hard copy, not only the soft copy of the antibiotic dispense prescription, along with the electronic one. And supposedly, MOPH, the Ministry of Public Health Inspector, can access to both records and to compare the number that we have in our stock and the number of dispense, and by whom. Is it by the pharmacist or it is under the prescription? We don't have lack of time. It is a worldwide problem. The economic situation, no remunerations or compensation. There are barriers to pharmacists' willingness and cooperation in data collection. Why pharmacists are going to ask themselves, why do we have to give this time in data collection? Why we want to give this for free of charge? So they are not interested even in data collection. Community pharmacists used one of the programs, which is the soft farm, in their computers, in their system. And this one will allow us to manage the medicine inventory in general. So we can track the number of antimicrobial that are prescribed in our pharmacy. And if we want, we can analyze the product usage, the ordinary patterns, the patient demand. We can use this software if we want, if there is the willingness. But the barriers of time and remuneration and all others will make the pharmacist uninterested on this. So data collection is really quite challenging at the level of community pharmacies, not only in Lebanon, but to be honest with you, in all low and middle income country. But we have to find a solution, because data information and collection is very important, not only in AMR, but to know how to deal with diseases and how to prevent and to prepare for these problems. Next slide, please. Lastly, I would like to talk about one new attempt with Meditrack, the Ministry of Public Health, who in 2017 has launched a new IT program, which is the Meditrack. In October 23, I mean, after almost, I don't know, 5, 7, 6 years, community pharmacists were involved in this Meditrack and received sessions on how to use the program. What is this program? Well, this program will allow pharmacists and the Ministry of Public Health and the suppliers to have a safe drug access to the patients, because we will fight the counterfeit medicines, because each medicine will be tracked to control the dispensing of medication, especially the antimicrobial, visibility and protection from the point of manufacture to sale to the consumer. And we can have a fast recall if there is a problem from the market. Next slide, please. As you can see in illustration, this system will allow a different interaction, all these patients, all these elements, the producer, the importer, the warehouse, the hospital, the reimbursement institutions, and the pharmacy are all connected to the Meditrack system, which is the Ministry of Public Health. So, for instance, for the pharmacy in particular, if I'm going to prescribe, to dispense an antibiotic without the prescription, at the same moment, the Ministry of Public Health will be aware of this, and they can track if I dispense it without a prescription or with a prescription. Next slide, please. But till now, Meditrack doesn't track these and traces antibiotic. It only traces medications that are distributed free of charge by the Ministry of Public Health. By that, I mean the niche market, the rare diseases, the onco treatment, and not antibiotic and not NCDs medications. So till now, the tracking of antibiotic is not done. So unfortunately, till now in this phase. Next slide, please. How to improve, finally, the data collection at the level of community pharmacies in low and middle income countries? Of course, we have to establish robust surveillance systems to monitor antibiotic use and resistance patterns is vital. And the example, for instance, what they are doing at the primary healthcare centers is a good initiative to have it. And the implementation of law is very important. Community pharmacists can contribute by reporting antibiotic sales, dispensing data, suspected cases of inappropriate antibiotic use, but they have to feel that they are integrated. They have to feel, they have to collaborate, they have to be remunerated, they have to be well educated about the consequences of not reporting data at the level of the of Lebanon even. Integration, so they have to be integrated about it. And training and education about surveillance and AMS indicators, especially at the level of the community pharmacy, is very important, because pharmacists at the level of the community, they don't understand well the importance of surveillance and how to track information and when to track information. So community and community pharmacist collaboration is very important. The stakeholder engagements to facilitate the data collection and intervention strategies is facilitated when we have this intercollaboration and cooperation. Linking pharmacy data to national health database will help us really a lot and make a huge step. Thank you very much.
Thank you very much, Luna. That was an excellent presentation on the challenges that you're facing in Lebanon in relation to data in this space. I think it was just very, very, very thorough, and you've covered the community, the primary care network, and the hospital pharmacies as well. So just to remind you that if you want to ask questions of Luna and our next speaker, Mary, please put your questions into the chat box or into the Q&A, the Q&A box, which is at the bottom of your screen. And without further ado, I will introduce you to our next panelist, who is a colleague of mine here in Ireland, and that is Mary Philbin. Mary is the AMRIC Chief Pharmacist in the Health Service Executive in Ireland, and AMRIC stands for Antimicrobial Resistance and Infection Control. Mary has extensive hospital experience and was instrumental in developing guidelines during the Health Service Executive's response to the COVID-19 emergency here in Ireland, developing many guidelines on infection control. More recently, Mary's been instrumental in developing the community AMRIC prescribing and dispensing guidelines in Ireland, and she's going to present today on harnessing the power of data to use it in antimicrobial stewardship in community pharmacy settings in Ireland. Thank you.
Thank you, Paul, for the introduction, and thank you to FIP for the invitation to present to you all. It's a fantastic opportunity to present on such an important topic to you all. So yes, I would like to share with you what we have done with one set of data in Ireland in the community settings in relation to antimicrobial stewardship. So if I can move to that slide. Thank you very much. So I've highlighted here on this slide 3 key documents really that drive our work in Ireland in relation to antimicrobial stewardship. And it helps set the background to my presentation. So the first document is Ireland's second One Health National Action Plan on Antimicrobial Resistance. So this is published through a joint effort of the Ministries for Health, the Ministries for Agriculture, and the Ministry for Environment. And out of that then feeds into the centre document there, which is the Health Services Action Plan. So it's those actions taken from the One Health Action Plan and translated into the actions that are required for the health service. And this is the action plan that we deliver on as the National Antimicrobial Resistance and Infection Control Team in the health services in Ireland. And this is applicable to all healthcare settings across the country. And also to further our work in this area, we published antimicrobial stewardship guidance for all healthcare settings in August 2022, and that's the final document. And all of these, if you search for them in your browsers, the links are publicly available. Next slide. So we have done significant amount of work in the community setting in Ireland. I think across the globe, really, a lot of stewardship efforts have been focused on the hospital settings. And it's now in the last couple of years that work is being focused or introduced, shall we say, in the community setting. So we have, as I said, we have done a significant amount of work, but still there's an awful lot of work to do. So one of the first things a number of years ago that was started with, and it's related to the visual on the bottom left of my screen, and what we refer to it is our antibiotic classification for the community settings. And our easy way of referring to it is our green-red antibiotics, our preferred and our non-preferred, and the non-preferred being red. So those green are those safer agents, they're narrower spectrum agents, and they're also effective, and that's a really important point for the treatment of the relevant infections. So this is distributed to all GPs and community pharmacists as a mouse mat. So it's very much there in the visual for prescribers and dispensers to know what the green antibiotics are. We have a website, again, publicly available, antibioticprescribing.ie, and that hosts all of the community antimicrobial prescribing guidance. So in the last year, there's been 2 million visits to this site. So again, it's growing every year as our efforts, and there's a huge amount of work that is done in the background to this in publishing the relevant guidelines and updating it. And the bulk of that work is done by our community antimicrobial pharmacists with support of expert advisory groups, and representation then on expert advisory groups will include the relevant national clinical lead. So if there's respiratory guidance being updated, then the national clinical lead for respiratory will be part of that expert advisory group. We have GPs as part of our national AMRIC team. And again, that's instrumental. If we're engaging with our community prescribers, it's important that we're doing it in the right context. And those GPs do a lot of GP education among their peers and GP trainee education. I've mentioned our community antimicrobial pharmacists. So again, they're central to these community prescribing guidelines. And they also do a lot of work in what we refer to as our health service funded inpatient facilities in the community. So that could be long-term care facilities for older persons, mental health facilities, etc. These pharmacists, there is one per what was, when they were initially established, community healthcare organisation. So they cover a population of about 500,000. So there's one per about 500,000 of a population, which is a huge remit for one person. But they're doing significant work. But additional resources are definitely required there. And we're also as well trying to upskill our community pharmacists. And an initiative we have created in the last couple of years is what we refer to as PALMSnet. So this is an online forum that any registered pharmacist in Ireland can join. It's a supportive forum trying to, I suppose, increase the knowledge and the skill set and empowering community pharmacists to deliver on antimicrobial stewardship as part of their day-to-day work. This is very much in its infancy. The numbers as a proportion of the whole register are quite low, but it's building all the time, and we're interacting and promoting it, etc. Next slide, please. So to set the scene in terms of where we are in Ireland, in terms of our volume of antimicrobial use, I've shared this slide from the European Surveillance of Antimicrobial Consumption Network, and this is from the 2023 report. This includes data on community and hospital. And you can see from this visual that Ireland is the 9th highest user in Europe of antimicrobial use. So we certainly have a lot of work to do. The darker colour represents the highest user, with the lighter colour representing the lower users. Next slide, please. And from looking at that data a little bit closer, what we have identified is that 90% of our antibiotic use in human health in Ireland occurs in the community sector. So it is really important that we focus on our efforts on improving antibiotic use in that sector. And the vast majority of our prescribers in that setting are GPs. So we really need to improve their antibiotic prescribing. And currently that data that I've referred to there that we contribute to ESACnet, that is wholesale data. Again, so that poses a challenge in terms of feeding back to our GPs and the ownership on their part of that data. So we needed to look at another route of getting GP prescriber level data that we could feed back and interact with our GPs. So in Ireland, a proportion of the population, possibly a third, have a social security card. If they're have a lower income and they qualify for such a card, so that means that they get their GP care for free and they get their medications for free as well. And then for community pharmacists to be reimbursed for this service, this data is submitted centrally for that reimbursement. So this is where we are getting our data to interact with our GPs. And what we have identified is that it is a good indicator of community prescribing. And GPs that participate in this reimbursement service as well, they also provide services to private private patients. So there is definitely what we would refer to as a crossover across the data. So if we improve the antibiotic prescribing for patients with social security card, there will be a transfer automatically across to our private patients. So it is a good focus of our efforts. So in mid-2019, we started providing a quarterly report to approximately 2,500 GPs in Ireland on their individualised prescribing rates of these green antibiotics versus the red antibiotics, including national rates and including a call for action within each of those quarterly reports. So they had their own data, and that was compared to national data. In 2022, we added in an additional metric in terms of the overall rate of prescribing. So that was their number of prescriptions per 100 GMS. Their social security, I'll refer to it as I'm speaking to an international audience, per 100 patients. We are currently reviewing those reports to incorporate an additional indicator, and I'll mention that later on. And also, we have in progress an intervention around the out of hours service, but again, I'll mention that later on. So if I can move to the next slide, please. So this, I've included this just to show you what, over the course of the next 3 or so slides, as to what these reports actually look like that the GP gets. So these are posted out currently to all of these 2,500 GPs. So each quarter we focus on one key message. We try and keep it as short and concise as possible, considering the huge workload that our GPs are currently experiencing. And this is the most recent key message that was circulated, and it's around improving prescribing to reduce antibiotic use for children in those common childhood illnesses and infections. Next slide, please. This is one of the graphs that appears within the report, and this is in relation to that antibiotic rate data, so the number of antibiotic prescriptions per 100 patients. And this is done on each data point refers to a rolling 12-month period, and we have a target national rate included in this, which is not visualized there, and then it compares to the overall national rate. So you can see on the left the dark blue bars relate to their own patients, so that's their own prescribing rate, and then in the grey bars that's the, I suppose, national cohort and how they're comparing to their peers, and it's broken down per age group. Next slide, please. And this then is what I refer to as the red-green. So again, on the left, prescribers can see how they're doing in their patient cohort, their level of green antibiotic prescribing in comparison to red, and how that relates to the whole data set, so to speak. So you can see for this particular prescriber, they have a higher level of green antibiotic use in comparison to the national cohort. And next slide, please. And again, this is just a sample of the key messages that we have included since we started doing these reports. We're on, I think, issue 23 or 24. So we have looked at or provided tips on deprescribing UTI prophylaxis, tips on safer use of azithromycin, managing respiratory tract infections in autumn-winter time, highlighted the reasons that amoxicillin is preferable to co-amoxiclav for the treatment of respiratory tract infections. So calling out messages like that amoxicillin is just as effective for your respiratory pathogens, that the clavulanic acid piece is only extending that spectrum unnecessarily, increasing the risk of generating antimicrobial resistance, C. diff, and then the additional adverse effects as well that exposes the patient. And again, in these messages, we really try to emphasize the patient safety aspect, again, because what we appreciate is that sometimes antimicrobial resistance is just a little bit out there. For prescribers, what's mostly their interest is the safety of that patient in front of them. So we tailor the message to emphasize that part. Next slide, please. So this is some data in relation to our work. since we started in 2019. So that you can see that we have had a significant improvement in the level of green antibiotic use in comparison to red. So we went really from a 50-50 split to now a 70-30. But as you can see, we have somewhat reached a plateau. So we need to do something about that. So next slide, please. And the next slide refers to the antibiotic rate. So I suppose, unfortunately or not, this rate was introduced to the reports in mid-COVID, where I think you'll all appreciate antibiotic use was at a significantly lower rate because people weren't getting these infections, the good hygiene, etc. So the need for antibiotics was a lot lower. I think it may also highlight the amount of antibiotic use that is for these respiratory illnesses. Anyway, that's a discussion for another day. So again, with this rate, we seem to be at a somewhat steady state. Next slide, please. And then, so that data on the last two slides that I have referred to is regarding that reimbursed data. And I want to share now over the next 3 slides is what is that data looking like? How is that translating to our overall national data? So this trend line that you can see here is the national consumption of antibiotics over the last 10 years. And the dip there is relating to the COVID pandemic. So you can see we really haven't made any progress in our overall use of antibiotics. Next slide, please. And what I'd like to share here is just one example of what we refer to again, as I mentioned, the preferred or the green antibiotics, so tetracycline, and this really is mainly made up of doxycycline. So you can see over the last 10 years, there's been a slow and steady increase. And I suppose this is a desired increase because again, these are the agents that we are as such promoting or we would like to see used in preference to the broader spectrum red non-preferred agents. And the next slide then, and I've just included the example of the quinolones. So you can see over the last 10 years, there's been a significant downward trend in the use of these agents. And again, that's overall total community consumption. So that's how we're doing nationally. And how are we doing in comparison to our European colleagues with regards to this overall consumption data? So again, back to the ESAC-net reports, and this is a table from the 2023 report that I have here on the right-hand side of the slide. And also, I'm sure a lot of you on the call are aware of the 2023 EU Council targets in relation to antibiotic use. So, from an antibiotic use point of view, the EU Council have provided 2 key targets. And the first one that I'm going to mention on this slide is that by 2030, at least 65% of total consumption of antibiotics within each country should be from the access group of antibiotics. And again, that's the WHO aware classification. And really in Ireland, the access somewhat transfers to what we are referring to as our green antibiotics. So we're actually doing really well in Ireland. So our efforts have definitely paid off in this regard. And based on the 2023 data, Ireland is actually at a 75% rate of access antibiotics. So we've reached our target. We definitely, that cannot as allowed take our foot off the pedal whatsoever. We must continue these efforts and continue to improve. Next slide, please. And we definitely need to continue these efforts because in terms of the overall antibiotic use, the news is not so good. We have a significant challenge. So in terms of overall use, the EU Council 2023 target is for all of EU to reduce antibiotic use by 20% by 2030. And then each country, based on their 2019 use, was given individual targets. And for Ireland, because we are on that higher end, we need to reduce our overall use by 27%. So this is a significant reduction that is required. There's a huge volume of work that will be required to reach that target. Next slide, please. So I suppose we have some of our work in train in that regard. And I suppose just to call out some of it here and what are we hoping to achieve. So we do have a revision of that GP report that I have referred to you in progress, and what we are going to incorporate is a marker of duration. Again, with the best will in the world, some of these data sets are not perfect, but we need to move with what we have and optimize use and use that to drive change. So we are going to report to GPs what percentage of their amoxicillin prescriptions are of a duration greater than 5 days. Because again, in a lot of our guidelines for respiratory tract infections, it has that shorter duration now of 5 days, which is evidence-based, which is in the literature. So we really have this respiratory Strive for 5 campaign in shortening the duration. And current indications in regards to our work in this regard is that there is potentially a 50-50 split between 5 to 7 days currently. So if we can get that duration back to 5 days, that should significantly reduce our overall usage. Again, each of our key messages going forward will focus on the reduction of overall use. So while maybe the messages up until now have really focused on that safer use, that narrower spectrum use, and you see we have made great progress in that, we now need to focus on reducing overall use, and that's why that most recent key message on the management of childhood infections was really important for us to include. There is a huge piece of work going on in regards to audit and feedback in relation to our GP out of hours facilities. So that's provided in a different format to how the GP daytime services are provided in Ireland. So we are now based on a pilot project in the south of the country, where they've shown that this antibiotic trigger tool as part of each consultation that the GP will complete at the end of the consultation has really improved antibiotic prescribing. So what it is, the patient comes in, the GP does the consultation, and as the patient leaves, a trigger tool comes up on the screen, and the GP answers it. Did I prescribe an antibiotic as part of this consultation? Yes, no. If I did, what was the indication for the antibiotic? What antibiotic did I choose, and what was the duration, etc. So then based on that data, we'll be able to give these out of hours GPs 2 monthly reports in a similar format to what I've shown for our daytime services in relation to their antibiotic use, and hoping again that that audit and feedback will help drive change and reduce overall use and improve the quality of prescribing for our patients in Ireland. Again, our GP colleagues will continue to do a lot of work in this. I've mentioned our guidance, how the reduced durations. Our community antimicrobial pharmacists that I've mentioned are doing a quality improvement project with the HSE facilities that they work in with regards to good urinary tract infection management. And there's a quality improvement project referred to as Skip the Dip. So it's about reducing the unnecessary use of urinary dipsticks in patients that are asymptomatic of urinary tract infection. And in the over 65s, if a patient is suspected of having a urinary tract infection, that it's not appropriate to use a urine dipstick to diagnose that. Another project that we are nearing completion on is short micro-learning videos on antimicrobial stewardship for our community pharmacists. So these are really short, less than 10 minutes videos that we hope will be useful to our community pharmacists. We've done a pilot project, and the feedback from that was really positive, and hope that that would be a flexible way of learning for our community pharmacists, because again, they're extremely busy. So if that can be incorporated into their day and is an easy way of learning for them, we hope that will again assist with reducing this overall use. And again, over the last few years, there's been a lot done in public awareness campaigns, and we will continue to do that. And I've included examples of posters that we do in this regard that are circulated to all of our GPs and our community pharmacists around the time of European Antibiotic Awareness Day, again, that assists in helping drive home this message. And the next slide just highlights some of the resources that I've mentioned in relation to the Skip the Dip campaign. And that leads me on to our next slide, our last slide. So I have a huge amount of people to acknowledge in regards to all of this work in Ireland in improving antimicrobial use. And I'll leave that there for your information. And thank you very much.
Thank you very much, Barry. That's a fantastic presentation. You've certainly done an awful lot of work in the last few years. Perhaps now, Jim, I'll hand over to you, and Luna, if you could make yourself visible, then we can start the Q&A session. I think we have a few questions in there. I'll hand over to you, Jim. Thank you.
Thank you. Yes, Luna and Mari, thank you for outstanding presentations. These were great. We do have some questions in the Q&A box, and I also have a few other questions, but I'll ask the audience, if you do have questions, please go ahead and enter them in the Q&A box. Mari, I guess I'll ask you one that's in here is, you mentioned the GP out of hours audit and feedback. Could you describe a little bit about how that's performed in Ireland?
Yes, thank you, Jim, and thank you to the person that asked that question, because it really is an important initiative, because certainly in Ireland, and I think there is some information in the international literature, is that the rate of antibiotic prescribing is often higher in these out of hours services, because again, the person that is seeing the patient is not necessarily familiar with that patient. So there's certainly a lower threshold. So it really is an important service to engage with in improving antibiotic use. So how we're actually rolling it out is, so if I am correct, there's about 16 out of hours cooperatives around the country. So we have had agreement from all of those to participate in this. And what we're doing is we're engaging with the software providers, so the commercial providers of the software for the patient record in these facilities. And this audit tool then will be, or this trigger tool will be incorporated on the front end of that system for the prescribers to utilize, and then the data will be captured that will be fed back to the out of hours. And again, this will be supported by education from the AMRIC team in this regard to prescribers, and obviously we will take forth the 2 monthly feedback and incorporating the key messages into that.
Great. Thank you. Luna, I guess I'd like to ask you, in Lebanon, sort of contrasting what Mari presented in Ireland, there's looks like a very organized approach to having direct and sort of simple messages to prescribers to help influence their practice. The website, the messages, all the different things that Mari talked about. In a country like Lebanon, Luna, where it sounds like less organized and government initiatives, do you have any suggestions on how pharmacists can work more effectively with prescribers to educate them on antimicrobial resistance and best practices in prescribing?
Well, the major problem in Lebanon or in low and middle income countries is that there is a deficit in the intercollaboration between the pharmacists and other healthcare providers, especially at the primary healthcare level. For instance, in hospital, at least we do have AMS programs that are implemented at least in the big hospitals, in the academic hospitals, and they have this committee where pharmacists is present and active. But at the level of the community, this is not happening. And in the mind of other primary healthcare providers, pharmacists has only to dispense. And if they're going to talk to the physician, or to say that is a long dose of that's the wrong treatment, they're not going to accept. And this is one of the major obstacles. So I think building conversations between primary healthcare providers at the level of the community is one of the pillars to enhance this, to enhance really this cooperation, and to improve antimicrobial dispensing and also prescription.
Thank you. You both spoke about, the need for data standards. This is a webinar about data to help improve this. And Luna, I think you mentioned that's one of the big challenges in Lebanon and a lot of low and middle income countries. Mari, I'd like to ask you a little bit about what you presented about data standards. I think I heard you say that the overall antibiotic consumption is largely measured through wholesaler data. Is that correct? Yeah. But I also heard you talk about initiatives looking at duration of therapy and things like that. So how are those data gathered and used so that you can make those types of assessments?
Okay, thank you, Jim. I suppose none of our data sets are really perfect. So this data set wasn't set out with these end goals in mind. And I suppose if I can share with all of the people on the call, it's about just making the best use, and I suppose interrogating that data to see what do you have that what I suppose can you take from it that will influence and improve practice. So that wholesale data, again, we know there's issues with that. The ideal is the prescribed and the dispensed level, and I think both data sets serve slightly different purposes, but your ideal is your complete dispensing data set and your prescriber level feedback, and ultimately it's your IT solutions that your e-prescribing, your shared patient record data sets that will really provide you with that. But and acknowledging the significant challenges that Luna has in that regard, please bear in mind that we have those challenges in Ireland as well. We're somewhat off an e-prescribing system. So in terms of that wholesaler data, look, it does give us some level of intelligence and information, and it's while we're awaiting the other data sources, look, it's still somewhat valuable.
Yeah, but I guess to the duration of therapy, are you deriving that from the limited e-prescribing data that you can just get access to, or how is that done?
Yeah, so in terms of the duration piece, what we're doing is that reimbursement data. So again, as I said, these durations are markers. They are by no means a perfect data set. So it's making assumptions based on the number of capsules or the number of tablets that are provided or dispensed on the prescription, or that reimbursement is sought for. So we're using it as a marker. So in the case of amoxicillin, we are making the assumption that 15 capsules is a 5-day duration. And we will call that out, and we will say to prescribers, this is the best we have, but we're trying to make the best use of the data.
Yeah, that makes sense. Yeah, and again, maybe another follow-up for both of you. In the United States, with our antimicrobial stewardship initiatives, and I'm mostly from a hospital environment, and I know we didn't have our hospital speaker today, but there's been a lot of debate here about what data standards we should use for overall consumption. primarily the discussion's been around defined daily doses versus another measure called days of therapy. I wonder if that's something that's been discussed in your countries at all, and if so, you know, how you ended up on the standards that you've chosen.
Okay, I'll take it first. If Lulu wants to, I suppose. Defined daily doses has been always used, and I think that's been influenced by what ESAC-Net look for ultimately. And I suppose it is an international standardized method, and there is the resources provided by the WHO for that. I really don't have any hard and fixed views as to which whether we should be using one data set over another. What I would say, I think we have maybe bigger challenges in the regard of improving the data we have, irrespective of what measure we're using. So in terms of our data capture and ensuring that we're actually, because we definitely, while we submit this data to ESAC and the wholesale, I think there's significant gaps that we're not capturing, significant data that we're not capturing. So I think we want to concentrate our efforts on improving the data capture rather than debating which measure will serve us better. And I think with any data as well, the important thing to recognize is its trends over time, and how are you doing in your trends over time, irrespective of what the actual measure is.
Yeah, Luna, do you have, I think you talked about the lack of standards being a real challenge, but has that been a discussion about what standards to use for overall consumption?
Usually at the level of hospital in Lebanon, the indicators, for instance, are the length of stay, the daily dose, the improvement. But as I have said, this is fragmented. Maybe one hospital will use standards, the other hospital will use other standards. But usually at the level of primary healthcare center, the standards that are using are always the WHO standards, because they are working under their guidance and guidelines. At the level of the community pharmacies, unfortunately, the only thing that we are hoping to, that we can have the synchronizations with the Ministry of Public Health Meditrack system, and then we can have indicators at the level of the community pharmacies. But as I have said, till now, antimicrobials are not in the plan, at least for the near future.
Yeah, the data, I think you both talked about how the data is so important for these initiatives. And I think in every country, we still have a long ways to go to get to where we want to be. I'll just briefly mention why days of therapy and defined daily doses has been a discussion in the United States, because in the United States, there's a requirement for hospitals to actually submit data now so that they can benchmark with each other. And one of the problems I think early on, we were primarily looking at defined daily doses. But what we realized when we started to try to benchmark between facilities were that defined daily doses wasn't really that helpful if you had a large pediatric population, for example. And so we were looking for a different type of standard that might help normalize that to some degree. So there's nothing perfect. I think, as you said, Mari, you do the best you can with the data you can gather. And, I'm sure we'll continue to refine this, but data definitely is going to be critical in these initiatives and in assessing the effectiveness of our antimicrobial stewardship efforts. I have a few other really good questions in here in the Q&A box I'd like to get to. I know we have a few more minutes. I wonder, either one of you might have an opinion on this. How adaptable are international antimicrobial stewardship monitoring tools for countries or regions with different infrastructures and regulatory frameworks?
Can I take this question? Okay. I'm going to talk about always low and middle income countries. I will leave Mary for the high income countries. So the experience in low and middle income countries is based on what is available, thinking about funding, resource, people, personnel, education, training. So the indicators are not very sophisticated between two brackets. It's going to be WHO guidelines, for instance, the adoptions of WHO aware book, let's say the simple process or manufacturing or pharmacy practice that are guided internationally. And then within the national action plan for each country, they're going to tailor these guidelines to be adapted to the context of this specific country. And this is the easiest way, because we don't have the luxury, for instance, to have different system, high IT system, digital system, lots of personnel, highly empowered, technical supports, etc. So we need to work on what is available and to find solutions. Thank you.
Great. Let's see. Here's a question for you, Mari. What advice would you have for low-income countries that are struggling struggling due to financial issues leading to a lack of appropriate first-line antibiotics, which sometimes leads prescribers to start with broad-spectrum antibiotics for managing patients? So I guess you've had that as an initiative to get people to prescribe the greens.
Yeah, and I suppose, look, that's a significant challenge, and it's something we do experience here in Ireland, to a certain extent as well, is because we are actually a small market, for pharmaceutical companies. So we're not always considered attractive for pharmaceutical companies to pursue licensing and marketing within Ireland. So it means that we don't have access to some of these agents. So, for example, pivmecillinam is an example, and then from the hospital perspective, cefazolin IV. So these are two, good green access antibiotics that you would like to have access to. So I think what we have done here, and again, for the person asking the question, I hope it helps somewhat, is that we have interacted with the medicines regulator to see, so they have some sort of flexibility within their gift, I suppose, to interact with pharmaceutical companies, to make it, say, that bit easier for them in this regard, because it's such a public health need to have these available. And so that's just my experience in trying to make these agents available. Another thing that's been done at a European level as well, and we have interacted with, I don't know if people have heard of HERA. So they're the healthcare emergency response unit that has been set up by the European Commission. So I suppose it's to help in European level preparedness for events like COVID, etc., down the road, that we're much more ready. But one of the things they're looking at is availability of medicines. So again, I don't know what country that the person asking the question is based, but if there's some sort of initiative in that regard, and what one of the aspects is, again, these difficult to source antimicrobials and increasing their availability.
I think I have time for one more question here. Luna, someone asked, you had described some of the data systems that are being used in Lebanon. The question was Meditrack added to the Phoenix system in Lebanon? And is it possible to integrate both of those systems?
It's not integrating. It is, let's say, cooperating between the two systems, because the primary healthcare centers are not intending to buy new systems, of course. And the Meditrack is cooperating between all, the big data collection will be at the Ministry of Public Health. For instance, when I'm going to use the Meditrack, which is happening now for the oncomedications, I'm going to use, I'm going to dispense the product, And then while my system, the soft farm, is synchronized with the Ministry of Public Health Meditrack system, the information directly will go to the system. Same story will happen to the Phoenix. If they want to do the collaboration with the hospitals, each hospital, for instance, in the American University of Beirut, they have the EPIC system. So they're going to synchronize the system. It is really the willingness to cooperate together. At least for the first step, it's not going to be the best system, but we can collect data, and the big system will be at the Ministry of Public Health. But we have to do this cooperation, collaboration between different stakeholders, and to accept this, to do this, because sometimes one of the stakeholders will refuse to share the data, and this is another conversation. Sometimes they don't want to share their information with the Ministry of Public Health or with everybody, and this is also a problem. But at least for the first step, let's share all of us the information with the Ministry of Public Health, and then we'll go for the second step.
Well, I want to apologize to those of you who may have asked some questions that I didn't have time to get to, but I want to thank both of the speakers, Mari and Luna, for excellent presentations again, and for excellent answers to the questions that we had. And at this point, I'd like to turn things back over to my co-moderator, Paul, to wrap up the program.
Thank you, Jim, and thank you, Mari, and thank you, Luna. They were excellent presentations, and you can see from the amount of questions and interaction from the chat, people were very much engaged with you. I think one thing that I'm taking from all this, and perhaps you agree with me, is that the pursuit of perfection is the enemy of progress. And I think what you've both said is that, yes, you're progressing with your AMS programs in your individual countries, albeit at a different rate. But yes, the data that you have isn't perfect, but you have to use what you have. And number one, you describe the problem, you quantify it using data, and then you try to improve how you can influence that data and manage that data going forward to improve the outcomes. And I that's what I've taken from this. Really, really very insightful. And thank you very much. So there's just one or two other things that I would like to bring to your attention. So thank you to Jim as well for co-moderating, and he would have more of a domain knowledge in relation to antimicrobial stewardship than I would. So thank you for doing that. Again, thank to our panelists. Again, I'd like to thank Isu and Albina in FIP for organising it and guiding us through the whole process. The recording of this webinar will be available on www.fipevents.org. Please give us your feedback at webinars@fip.org. And also, just to bring to your attention that the FIP Congress will be on. The World Congress of Pharmacy and Pharmaceutical Sciences will be in Denmark on the 31st of August to the 3rd of September. I would encourage you all to go. I've been to FIP Congress several times. It is a fantastic way to get ideas from other countries, what's happening, learn through innovation, learn through transfer of knowledge, learn through networking. And also the day before the Congress starts, on the 30th of August, FIP will hold separately a digital health summit, which you need to register for through the portal for the General Congress. The FIP Digital Health Summit is a separate event, and that will look at the whole area of how AI can be used to harness, to improve the workflow and the lives of pharmacists, and to improve and optimize patient care going forward. So I'd really encourage you all to register for that if you can. With that, all I can say is, listen, thank you very much for your attention, and hopefully you'll have a good day.